The broadcast is now starting. All attendees are in listen-only mode.
It's okay. We're going to wait a few seconds for everyone to join the meeting today. Welcome again, everyone, to the Zero Suicide webinar series. Today's webinar, the third in a 6-week series, is Using the Zero Suicide Organizational Self-Assessment. This event is brought to you by the Center for Health and Learning and the Vermont Suicide Prevention Center under funding from the Vermont Department of Mental Health. Again, I'm Zan Lewis, Program Specialist at the Center for Health and Learning, and I will again be the moderator for today's webinar. Just a reminder to everyone that these webinars are being recorded and will be available on the Vermont Suicide Prevention Center website 1 week after they are broadcast. Later in the webinar today, Joellen will share an updated link with you all. You can also email info@healthandlearning.org to request a password access to the recordings. For anyone who is new to this webinar, I want to just take a few minutes to provide you some reminders that will make the webinar run smoothly. If you have a webcam, we do recommend that you do not use the webcam function for this broadcast, and it would be best to turn that off now. We assume you are all connected by audio at this point. Your choices for audio are to go to the audio section of your control panel, choose mic and speakers on your computer, or to choose telephone and dial using the information provided. If you are having any problems at any time, please feel free to type a message in the chat box directly to me, Zan Lewis, and I will respond with a message directly back to you as soon as I can. We have scheduled 60 minutes for today's webinar. During the presentation, we have found that it is best to mute all participants. When you have a question, please feel free to type your question into the questions pane on your control panel, and I will ask the presenters as soon as I'm able. Thank you for your patience if it takes several minutes to do so. Finally, as a quick reminder, when the webinar closes, an evaluation will come up on your screen for you to complete in that space. Please make sure to stick around at the end to complete this evaluation because we will utilize your feedback. I will now introduce our 3 presenters, Joellen Tarallo, Tom Delaney, and Michael Hartman. Dr. Joellen Tarallo is Executive Director of the Center for Health and Learning and Director of the Vermont Suicide Prevention Center. Dr. Tarallo is a state and nationally licensed health educator, trainer, school administrator, program developer, and project manager who works at the crossroads of education and public health. Tom Delaney is based in the Vermont Child Health Improvement Program in the Department of Pediatrics of the UVM Larner College of Medicine. He earned a PhD in psychology from the University of Denver and started doing research and program evaluation work on suicide prevention in 2009. He has been the evaluator for 2 statewide youth suicide prevention grants, and since 2015 has been the evaluator for the Vermont Zero Suicide Pilot Project. He teaches research methods, statistics, and mental health-related courses at UVM. Michael Hartman has worked in the field for almost 40 years, from part-time residential worker to Vermont Commissioner of the Department of Mental Health, and is now Director of Behavioral Health at Lamoille County Mental Health Services. I'll put Michael's full biography in the chat box for you all to read. Thanks, everyone. It's good to see you all here again, and I will now hand it over to our presenters.
I'm sorry, I had forgotten to unmute. Good morning, everybody. This is Joellen Tarallo, and I want to welcome you to the 3rd webinar in our webinar series on zero suicide. This webinar is using the Zero Suicide Organizational Self-Assessment. We have a wide variety of people in our audience today representing healthcare. We have people from hospitals, emergency departments, and inpatient units. We have people from primary care, including allopathic and naturopathic physicians, nurse practitioners, RNs, and practice care coordinators. We have representatives from federally qualified health centers and designated mental health agencies and independent providers. We also have school health staff from schools, school nurse and psychologists, social worker. Thank you all for participating as a community of learning as we all learn more about zero suicide, shore up our skills to implement. Vermont Suicide Prevention Center is a public-private partnership aimed at providing cross-disciplinary and cross-sector access to best practices for suicide prevention. Under funding from the Department of Mental Health, we have partnered with the American Foundation for Suicide Prevention Vermont chapter, the University of Vermont Child Health Improvement Program, as well as designated mental health agencies in Vermont from the beginning of the partnership. The Vermont Suicide Prevention Coalition, that draws its membership statewide and meets quarterly, advises the Vermont Suicide Prevention Center. If you're interested in being part of the coalition, please contact us and we will add you to our listserv. I'd like to thank our partners today, Dr. Tom Delaney from the University of Vermont and Michael Hartman, Director of Behavioral Health Services from Lamoille County Mental Health. During this webinar, participants will be introduced to the Zero Suicide Organizational Self-Assessment as a leadership engagement and program planning tool. We will talk about how the OSA has been implemented in Vermont Zero Suicide pilot projects and in other organizations. And we will also consider the next steps in your planning. Before we start, we'd like to ask, what questions do you have? While you will be on mute during the presentation, we encourage you to type questions at any time into the questions box. So please type any you may have right now and at any time throughout the webinar. Zan will moderate those questions when we have an opportune moment. And as Zan said, because it's often a question that comes up, within 1 week of this webinar, the slides and a recording will be available at Vermont Suicide Prevention Center website on the Zero Suicide page, which will direct you to towards the end of this webinar, and they will remain there through June 30th, 2019. We want to give you forewarning that a poll will pop up on your screen during this webinar. When it does, please participate. Zan, do we have
Joan,
any?
I have a question for you.
Okay, very good.
I do. And the question is, what is the current budget? And I imagine that is for what is the budget of Zero Suicide, but feel free to let me know if that is wrong. And how much of the budget goes to salary versus program resources?
Oh, goodness. So the Vermont Suicide Prevention Center is a public-private partnership. It is supported by a state allocation from the Department of Mental Health. That allocation has gone from $50,000 throughout the years. It varies year to year. Currently, our allocation is about $220,000. We raise the rest of the budget, which is about double that, through projects we build out with partners funded by foundations. We have the You Matter Youth and Young Adult Project, as well as private donors and donations. I would have to get back to you on the salary versus program question. We'll be happy to do that. But I can say that it takes a fair amount of human resources to plan, organize, provide technical assistance, and offer the programs. I'm going to guess that it's about 60% at this point in time salary and about 40% program. But I'd have to get back to you on that. These are Vermont statistics released in summer 2018 from the Center for Disease Control and Prevention. In 2016, 118 people died by suicide in Vermont. If we average this number across the year, it means that one person dies by suicide every 3 days in our state. Across all ages, suicide is the 6th leading cause of death. However, for these ages 15 to 34, it's the 2nd leading cause of death. In Vermont, more than 10 times the number of people die by suicide annually than by homicide, and 2 to 3 times more than die by traffic fatalities. This may be surprising because the media reports more extensively on homicides and fatalities. We also want to point your attention to the metrics that Vermont has committed to in the all-payer model. Goal number 2 specified reducing suicide deaths. Vermont is in year 2 of a 5-year all-payer commitment. There will be a review in the final year to track progress, and Vermont will need to develop improvement plans based on the review. The Center for Medicare and Medicaid Innovation will assess the state on its performance on the all-payer model measures framework to determine whether Vermont's model was successful in impacting population health outcomes. Vermont has chosen this target as a metric of success. Reaching this metric will necessitate adoption of principles and practices of a suicide-safe pathway to care. Also at the beginning, we want to mention that one of the primary goals of Zero Suicide is to destigmatize mental health and suicide prevention services. We now understand more about suicidal behavior and the impact language has on perpetuating stigma and misunderstandings about suicide. In addition, the survivor loss community has focused on sensitive use of language. So we'd like to draw your attention to the left side of the slide, and please use those phrases. This takes practice, and we encourage us to remind each other as colleagues about the use of sensitive language. We also wanted to provide the context for this work within the overall Vermont Suicide Prevention Platform, which is a guidance document in Vermont published in 2015 by the Vermont Suicide Prevention Coalition, representing cross-disciplinary and cross-sector professionals and consumers, representing survivors of suicide loss as well as survivors of suicide attempts. The Vermont Suicide Prevention Platform is written in an ecological, socio-ecological format where we specify recommended practices and objectives based on national practice and research for various levels of the system and sectors. This webinar today on Zero Suicide relates directly to goal number 7, promote suicide prevention, screening, intervention, and treatment as core components of healthcare services with effective clinical and professional practices. The platform can be found at www.vtspc.org, Vermont Suicide Prevention. So now we're going to turn our attention to Zero Suicide, and in particular, the use of the organizational self-assessment as a means of organizing an organization around launching an initiative and a change process for implementing the practices and principles of Zero Suicide. As we've discussed in the previous webinar, there are 3 central facets of Zero Suicide. The first is core values, which really focuses on continuity of care and shared service responsibility, promoting a culture of shared responsibility between different elements of the system. It also stresses immediate access to care for all persons in suicidal crisis, a very critical part of the suicide-safe pathway. The second element is systems management, policies and procedures which facilitate referral, follow-up, care coordination, identification, assessment, etc., collaboration and communication, both between professionals and providers and through an electronic medical health record, and a trained and skilled workforce. In addition, evidence-based practices are a critical element of Zero Suicide, and as we've discussed earlier, those elements focus on systematic suicide care for screening and assessment, safety planning, treating suicidality, and continuity of care, including follow-up. This is a Vermont-developed graphic which shows the tasks ahead of us to create strong linkages between every element of the system that creates a suicide-safe pathway for people who need help. This graphic is designed to underscore how critical it is to have strong linkages, care coordination, and communication mechanisms in place to ensure that excuse me, previous clinical assessments and efforts between providers and services are part of a comprehensive system of care. This is Vermont's graphic for showing the Zero Suicide system across a continuum of care and specifies the evidence-based practices we have chosen to use for each level of the system. At the base are universal strategies, which include gatekeeper training, which was the focus of the first webinar in this series. You will notice that between each level of service intervention in this system of care, there is a gray banner that specifies care coordination, follow-up, and ongoing caring contact with the patient, which, as it turns out, is a critical element of the suicide safe pathway. Webinar 6 will focus on follow-up and care coordination. These are the things leadership can do to support the implementation of a zero suicide approach. The use of the organizational self-assessment falls under the leadership element and falls within a comprehensive planning process as an assessment and planning tool. When an organization commits to undertake the OSA, they bring together a core group of people who can bring knowledge and perspective to the assessment. The assessment then informs where they want to identify priorities, including human resources, training, support resources. It also enables you to identify organizational outcome measures, which you want to track to measure your progress and impact. At this point in time, I'm going to ask Tom to talk about how the organizational self-assessment fits into leadership of the Zero Suicide Initiative.
Thanks, Joellen. If we can go to the next slide. So just very briefly, I'd like to mention the overall evaluation. So we're in year 3 of a pilot study of the implementation of zero suicide. And we have several different facets of that evaluation. The first is that we evaluate before and after trainings of the clinicians who participate in the collaborative assessment and management of suicidality. And that's an evidence-based practice that's being promoted as a core workforce development aspect of our pilot project. We also do interview studies with key informants from each of the participating designated agencies. We have adapted from the National Zero Suicide Effort a Vermont version of a workforce survey that's conducted with all the zero suicide teams at the different agencies. We've also collaboratively identified with the DAs 6 client-level measures that are collected across agencies, I should say across all agencies. And those are actually from national recommendations. We identified 6 from a menu of about 18 measures that we felt were achievable, and that also reflected the capability of the electronic medical record systems that are being used. The main focus of the next few minutes will be on the organizational self-assessments, which we do annually, which I might call OSAs. And I also want to make a plug for a brand new element that we just started brainstorming last summer, and we're about to start doing interviews with clients who have graduated from CAMS and zero suicide treatment. So here's a screenshot of the start of the organizational self-study tool. Really, the best way to begin your work on zero suicide is to use the Zero Suicide Organizational Self-Study, which can be very helpful for your team in thinking about your objectives and assess your current capacities, strengths, and gaps that may exist in systems and services. It can add a lot of structure to your thinking about suicide prevention in your system, as well as provoke important linkages or identify important linkages and provoke discussions. The tool is used nationally and as well as in the Vermont implementation at the agencies, and is available at the National SPRC website. And at the end of this webinar, you'll be provided with links and resources for that. Wanted to say that we've used this tool pretty successfully across the 3 pilot sites that are the Howard Center, Lamoille County Mental Health Services, and NCSS in St. Albans, Franklin County. In each case, there's a champion who provides leadership and coordinates the OSA effort and serves as the liaison to the VTSPC, who is the overall designer and manager of the pilot effort, and who collaborates with me, who's based at UVM. Next slide, please. So just a really quick overview of the tool. It was developed by the National Zero Suicide Initiative, and it's used across lots of different settings and different types of systems, including healthcare, mental health, behavioral health systems. And we're an early adopter of the tool, and we've gotten pretty good feedback about how we're using it. So in Vermont, the OSA is completed annually by the pilot site teams. It's really aimed at helping the organizations understand which aspects of zero suicide they're strong in versus which aspects need more focus. It's been used pretty extensively for planning training activities, protocol development, and other zero suicide related activities. It has a total of 18 items, and those are organized along the main zero suicide principles, of which there are 7, and typically can be completed between 1 and 3 meetings. So over time, I think the teams at the DAs are getting a little bit faster. So now we're more like 1 meeting to fill out this tool collaboratively. Next slide. So just to continue with Vermont's approach, it is collaboratively filled out. So it does involve having managers and leaders from different services come together. And so at some of the designated agencies, this has involved having directors of behavioral health, along with people from crisis services, adult outpatient, disability services, children, families, things like that. We've also noticed that the OSA is conducted slightly differently at different provider agencies. So the actual number of participants and services that are represented might change. It might change from year to year or from agency to agency, and the time taken to complete the tool might change. We try to always have the evaluator, me, be part of the OSA administration at each site. And that's really because we noticed at the very beginning of the project that there's a fair amount of interpretation that happens when people are discussing and then scoring each of these 18 elements. So we feel like having a common person across the sites helps promote more consistent understanding of the questions and the wording, promotes consistent scoring, and then it also really helps with our program evaluation because we take our own notes and then we get summaries from each agency about how they're using the OSA. Next slide. So just really quickly, the OSA for each of those items gets scored specific to the particular question, but then there's also a general scoring rubric. And so teams rate themselves typically using a consensus process, and the low end of the scale will be 1, so that a particular aspect of care, for example, counseling about lethal means safety, might be routine care or usual, and that would be towards the lower end of the scale. And at the higher end, an agency might rate itself as having comprehensive practices in place for lethal means counseling, that type of counseling is embedded probably in the electronic medical record, and that there's monitoring and maintenance of the use of that counseling or application of that counseling with clients, and that it also might be a focus of continuous quality improvement. Next slide. This is an example of the type of reporting that we've developed to share back with the agencies implementing zero suicide and also with our partners at VTSPC and the state. So this would be for a single agency, and the bars on the lines on the right represent changes or not changes across 3 time periods, so 3 annual administrations of the OSA. And then on the left, in that column, we have each of the domains. So for each domain, there might be between anywhere from 1 to 3 different items that then we create a standardized score for. So it's sort of like an average of all the items within that domain. And you can see, looking at this agency's example, they've made what appears to be remarkable and noteworthy improvement in 5 areas. And they have one area which is pretty flat. That has to do with ensuring that every person has a suicide care management plan on the pathway to care, which we're learning has been a little more challenging to develop over time. And then they might even have a very slight negative trend on providing continuous contact and support. So feedback like this, I think, is fairly helpful to the agencies for thinking about where they might want to focus on in their coming time. And at this point, I think we're going to transfer to Michael Hartman.
Hello, everybody, and good morning. Welcome to the webinar. The areas that I just want to go over briefly are the actual application of this inside of an organization. And so I think the first area that we would want to focus on is the assembly of the team, because it's really a key piece to that. And in part, that assembly is also a key piece to that assembly is leadership support. So in other words, with leadership expressing the clarity about taking this on as a mission, you then can go to each section. In our case, we have somebody from every division of the agency. We have children's mental health, adult mental health, developmental services, crisis services, and we also include people from the administrative part of our organization. In a larger organization, you could have other players, say in a hospital, it could be the housekeeping crew and security. I think the idea of this is that you want to have as many of the patient contact personnel in your agency or institution to be able to know how you can apply some of the areas of the organizational self-study and zero suicide. So in our case, we have the intake, we have nurses, we have psychiatric prescribers, folks from our developmental services, emergency services, and admin. And then most especially, I think, is important is that we have a person whose role in the committee that we formed is solely as a survivor of suicide, in this case, a parent of a person who killed themselves. And that role is extremely useful in terms of helping to ground the committee to the experience. Our committee has other members who have survived suicide or attempts of suicide of family members, friends, etc. But I think that having somebody identified specifically in that role really helps all the process of the team. So after assembling this team, I think that the way that we went about doing the tool, and we're just in the tail end of doing it for the third time, is gathering the team together, going through the questions. To prepare ourselves for doing that the first time, we went through all the policies and protocols and anything that described practices around how we currently were addressing suicide. And we didn't go at that with any idea of changing those things yet, just really measuring what they are at the moment. So that has been helpful to us to then establish what needed to change and in making the appropriate measure of where we were at. This has been extremely useful. I think as Tom pointed out in his part, that there were one or two areas that we had much higher changes of practice and impact on the persons that we serve, especially in the area of evidence-based practices. But really, out of all the 18 areas that are looked at through the OSA, we actually, in the one that we just completed for this year, found improvement in 17 of the 18 areas. So I think that it gives you a good sense of are you making progress, where are you stumbling, how are you stumbling, and helps you focus on what exactly you would need in your plan to create a better outcome in the year ahead. I think that we've utilized, after the first one we did, as we moved on to the next ones, we've been able to utilize the workforce survey as a way of getting feedback. We've certainly been open to getting feedback from our various client-based committees to give us feedback on that, as well as individual feedback from persons who use the pathway process. And that's another benefit of this in terms of using the OSAs, that by the end of the second year, we had established the basic platform or pathway for people to follow once they've been identified as at risk. And by using this tool, we're able to identify how we're doing with that. In the end, it helped us build a fairly extensive protocol guide for all staff in the agency here and focuses on what their role is and what they should be aware of and what they should be able to perform in terms of duty in that role related to suicide. We were able to establish a basic bottom line for what everybody in the agency should be able to do, and that's basically to ask 2 questions related to wellness and suicide. And then, especially from there, know what to do if they got positive responses to those screening questions. Where do they go next? So the emphasis was on making sure that people had an idea of their role and what the next steps were. And then through the OSA, we've been able to fine-tune that this year and further develop it as a process that's helpful to share with staff. This organizational self-study is not a secret document. It's a document that you would want to share with the agency or the organization that you're working in. And one of the applications we're looking at it right now is whether we can use this in its current form as a community planning document, because there's been a move in our area to consider bringing in all of the healthcare and human service agencies together to be able to create a zero suicide community, and that the organizational self-study would be a way to help gather a lot of information over a broad area to do that. So I think we've found that this was a really helpful tool in organizing what we were doing. It's been a very good tool to evaluate where we are on an annual basis, and it's been an excellent tool to help guide us into the next step, the next year of planning and activities that we were hoping to provide. So I think that it's not as Tom pointed out, as each year we've done it, it's gone faster. It's not a really complicated document, but again, having people from across your organization so that you can get a good sense of where the whole organization is in one score. And the bigger the organization, the more difficult that task is. So, but it does provide an excellent landing place for you to start on the next process of actually creating a plan and implementing. And I think that pretty much covers the area that I wanted to speak to today.
Great. Thank you, Michael. I'm wondering if you could say a word about pilot project participation, the benefits thereof, and technical assistance from Tom Delaney at UVM and Vermont Suicide Prevention Center.
Oh, certainly. I missed my bullet there. I think that the excellent part about this project has been we were a latecomer. 2 agencies, Howard and Northwestern Counseling Services and Supports, were identified early on. We were able to step in just behind them and get the benefit as a pilot project of being able to have the resources of the VTSPC and the Center for Health and Learning to aid us in materials and in giving us directions sometimes when we really weren't sure what to do next, in linking us up with Centerstone, which is a mental health organization in Tennessee that has a lot of experience doing this, which was really helpful for us as a mental health agency to figure out how we needed to structure things. And then in terms of Tom's role, I think that it's been really wonderful to be able to have an independent evaluator who is also sometimes a cheerleader and is able to help us. Sometimes we get very hypercritical at times about what we're doing, and Tom has helped us to remember that we're in a change process and that takes an enormous amount of energy at different points to make the change happen. And that sometimes we're so close to the subject that we don't recognize what a significant change we may have already made in something or are in the process of making. So I think both sides have been, both the center and Tom have been really helpful in keeping the project going. These kinds of efforts, I think there's really no special funding, there's no dedicated position for the work that we're doing. So along with doing UMatter training, mental health first aid training, which we're already doing, Zero Suicide has kind of come in as an ongoing project, and having the help and attention from both Tom and the center have been key in keeping this rolling.
Well, thank you, Michael. We have found that we're all early adopters in this effort at present, and the amount of collegiality and sharing varying perspectives and different organizational settings have provided a very rich dialogue about the challenges and opportunities that we're all facing. And Tom's technical assistance, somebody asked earlier, our budgets include all of the training that goes out to people, as well as the evaluation, and the evaluation is a really critical part, so that we can take a look across agencies or within agencies and get a sense of where we are now, where we want to go, and then the OSA really helps you think about how you want to get there. So thank you. So right now we'd like to take a moment and put a poll up. The poll questions will be as such. And then after the poll, Zan will moderate the incoming results and then report back to us, so we can get a sense of where people are in the field in terms of thinking about initiating a zero suicide approach in their organizations. And then we'd like to have a chat. And so during the chat, you would use the chat box, write in your thoughts. Our questions are, what are your hopes and concerns for this, and what would be helpful to you as we think about technical assistance to the field and the tools and resources you may need? So the first question on the poll will be, do you currently have plans to create a core team to advise and move forward on a commitment to zero suicide? Yes or no? And the second question will be, will you consider implementing the Zero Suicide organizational self-assessment as a step in the planning process? Yes or no? Zan, you could launch the poll.
Great, so you should see it come up on your screen, the first question, and I'm watching some of the results come in right now, and we will wait about 5 to 10 more seconds before closing it, and I'll share our results. Great, I'm going to close this first poll. All right, and our results, which I'm sharing on the screen, are to the question, do you currently have plans to create a core team to advise and move forward on a commitment to zero suicide? And 62% of respondents replied yes, and 38% replied no. And I will launch the second question momentarily. All right, so I just launched it, and as a reminder, the question is, will you consider implementing the Zero Suicide organizational self-assessment as a step in the planning process?
How do I get back to me to unmute myself?
Click staff.
Wonderful. So in about 5 seconds, I'm going to close the poll and share our results. Thank you for participating. Closing the poll now. And you'll see the results come up on your screen. And 83% of respondents replied yes to this question, and 17% replied no. Thank you for participating. And Joel, and I will hand it back to you.
Thank you very much. That represents a significant commitment to this initiative just by virtue of the fact that the leadership in the organization is giving thought to how you're going to assess at the beginning where you are and what capacity you'll need to build to move forward. And we really encourage you to take that time to do the assessment. That's why we have 2 webinars, one on OSA, organizational self-assessment, and next week on using the Workforce Development Survey. because by gathering your team together, you'll be able to think very thoughtfully about how you move forward and identify some priorities, and then think about the resources you'd need to have in place to actually move into implementation. That information is also really helpful for us as we think as a coalition statewide about engaging our stakeholders, whether they be the leadership in our health organizations as well as at the state agency level. And there are some state agency representatives on the in the attendance today. Thank you for that. As well as our legislators who are very concerned and interested. We'd like to invite you to attend our Suicide Prevention Day at the State House, which is now set for February 14th. That will begin at 9 a.m. in the morning with a press conference about the engagement of healthcare in developing zero suicide and or suicide-safe pathways to care, and then training for our participants in the Vermont Suicide Prevention Coalition, training offered by the American Foundation for Suicide Prevention around talking to your legislators about suicide prevention. And then the coalition representatives will be meeting with legislators over lunch. And in the afternoon, we'll have the privilege and the honor of being represented in the chamber, presented in the chamber by Representative Ann Donahue in Vermont, and a full resolution will be written and read related to suicide-safe pathways. It's a very emotional and moving experience. Our survivors stand at the doors to the chamber and pass out flowers representing one Vermonter who has died by suicide in the past year. We do hope you will join us. We've gone from very low level of awareness about this as an issue to high level of awareness. And now it appears that we also have real commitment and engagement in thinking about moving forward on the steps we can take. So together we thank you and we look forward to moving forward. As we move forward, we'd like to know, as you sit right now, what are your hopes and what are your concerns? And what would be helpful to you? So if you would take a few moments and just write some thoughts, questions, or comments into the chat box, Zan will moderate those and we'll be able to share as a learning community.
Great, and Joellen, I have 3 questions. If we can ask those after the chat, that would be great. You can let me know when works well.
Zan, I'm going to let you make your own, decision about when you want to present both the chat and the questions.
Great, thank you. I think I'll get started on the questions, and I will also keep an eye on the chat for anyone who wants to chat in about the prompt on the screen. So the first question is, what percentage of case managers are chaplains or members or leaders in faith-based communities? I was wondering if you had that data or knew where to find it.
And could you repeat the question? I love what it's asking about, but I just want to make sure I hear the question again.
Yes, absolutely. So the question is, what percentage of case managers are chaplains or a leader in a faith-based community?
I really don't.
And it may be that it's specifically chaplains, or it may be that the data is inclusive of the leadership piece.
I really don't know the response to that, but as we're building out the focus of the work on follow-up and care coordination, I'll be happy to try and look into that. We earlier in our work around suicide prevention in Vermont did some strategic engagement around faith leaders We did not work particularly with chaplains in medical settings, but I think that's a very good idea. We do have prevention and post-prevention protocols for faith leaders on the Vermont Suicide Prevention Center website, which I can point you to towards the end of this webinar. So I will look into that and look forward to representing some further thoughts about that as it plays out in Vermont.
Wonderful, thank you. And a question about the organizational self-assessment teams. Wondering, are school committee members involved on the OSA teams, either, Michael, at Lamoille or in other organizations that you're aware of, having a school representative?
Hi, yes. In the current agency self-study group, the committee, we don't have anybody from outside the agency other than the person who's a survivor. However, in the community planning group that we've just started in December, we have representatives from each of the school unions in our area, as well as from Johnson State College and Community College of Vermont. So we do see this as something that you would want that piece involved because of the risk groups that are addressed from 12, 11 on up to 18, 19.
Thank you, Michael. My next question is, excuse me, does Zero Suicide have prison delegate, or excuse me, I'll ask that again. Does Zero Suicide have prison designated Zero Suicide educators in Vermont?
This is Joelle, and I'll respond to this. Not at this time. I know that at the Agency of Human Services leadership team level, the Department of Corrections Commissioner has expressed interest in becoming involved with Zero Suicide and or Vermont suicide prevention initiatives and efforts. I'll make sure and let our leadership know that this question has come up. And it's one that I know our federal agency, Substance Abuse Mental Health Services Administration, is concerned about, especially with our youth and populations really across the lifespan who are engaged with not only juvenile justice, but correctional programs. We have a very long-standing relationship with the Department of Corrections through a representative who oversees their suicide prevention training. I will check in with him to see what they're doing with Zero Suicide in particular as it relates to healthcare. I know they have had a very strong gatekeeper training program and orientation that everybody who is employed at corrections is required to take. We'll look further into the Zero Suicide focus. Thank you.
Thank you. And I have a few more questions and hopes to share. So the next question is there a Zero Suicide lobbying to the Brattleboro municipality for funding?
Sorry, I have to unmute. This is Joellen. So I'm going to say in general, we have done no lobbying for this. All the work we do is stakeholder education. We provide education and outreach, public information about suicide. We try to gather the most recent data and metrics. We've been instrumental in the formation of a suicide prevention data and surveillance work group at the state agency level, and we participate in that, where a lot of focus on data metrics to inform where we are in the state and what we want to use for quality improvement measures gets discussed. So no, and not in particular, not with the Brattleboro area in particular. The Center for Health and Learning and the Vermont Suicide Prevention Center provides support statewide. We work with partners on virtually all of our projects, and those are found in the field-based different regions of the state. And we do have a project we're building out right now in Rutland on the western corridor of our state, between the regional medical center, the designated mental health agency, and the FQHC, federally qualified health center in that area. We're really just beginning to lay the track for partnerships and referral agreements between organizations that are suicide safe focused.
Thank you. The next question I have is wondering if someone can speak to the application of the organizational self-assessment and zero suicide safe pathways within small organizations. Is it necessary to form a team within small organizations or clinics?
Tom, I'm going to let you take that one.
Yeah, so that hasn't been a huge focus in Vermont because we've had designated agencies adopting in the pilot program. I would say what I've heard nationally and on the listserv is that even smaller agencies do definitely benefit and do participate in doing the OSA. So if you think about it as like an exercise that encourages reflection about your processes, your systems, and your services, you know, that's really where the great value of it is as an exercise. And also the items are informed by, you know, pretty much the best thinking in suicide prevention at this point. So I think that small organizations would benefit.
Thank you, Tom. I have a hope to share from a participant that this will help to bring together various service providers in the community on a deeper level by joining together and having conversations that ensure each organization's services can supplement the others. I think this would be helpful, and there's always room for improvement if it is already underway. And then I have one final question, which is, what is the budget to include zero suicide in every school and prison?
Let's see, attendees, help me, staff.
Yes, Joellen?
Oh, okay, I'm on. I didn't know if I was muted or not. I was calling out to our operations manager here. So I will respond to that. You know, somebody asked earlier about budget. These questions are interesting. There is no budget at this point in time around schools and corrections in particular. We have you know, every hour of staff time is charged to program. So we have at Vermont Suicide Prevention Center a variety of staff, our training and event coordinator, our operations manager who manages programs and reporting, to all our funders, state, private agency, et cetera, myself who directs the projects, program staff like Zan who are working on them. This webinar is supported as a program, so you know, all of our staff time developing it, et cetera. So right now, the deliverables in our contract with Agency of Human Services, Department of Mental Health, do not include specific deliverables around that. We actually, you know, are tracking objectives and priorities, and certainly working with corrections, especially if the Commissioner of Department of Corrections is interested in initiating activities, would be a priority. Thank you.
Great, thank you. Thank you all for your questions and for sharing.
Yes, and I'd like to say whoever provided the hope, we'd like to quote you because that is so well said. And I think the hope is also potentially the outcome. And so with that, we'll move on towards the conclusion of our webinar with just a couple more slides here. So this is one of the elements of the 7 elements of zero suicide, and that's improvement. And we've talked a bit about this already, applying data-driven quality improvement, which is one of the reasons we've been fortunate and have been able to place some emphasis on having an evaluator work with us on all aspects of the program initiation. The real intent is to use data to inform our changes and our program as we move forward. As we think about this, it's important for substance abuse and mental health providers to work together There are currently a lot of questions about the interrelatedness of suicide and opiate overdose in Vermont. Sometimes there's not a clear line, and this is something that we continue to have conversations about, as well as emerging concerns about marijuana use presenting increased risk for psychosis and psychotic symptoms, schizophrenia. For example, things that are being talked about in the research. This risk is increased with heavy use and high marijuana potency, 12% or more of THC. So we're constantly surveying the field for trends and what the research is telling us and trying to apply that to our work. I also wanted to talk about populations at higher risk based on the data. We identify in Vermont, and often this is reflected in national demographics as well, populations that are at higher risk. These populations have unique risk factors, but also risk factors that certainly cross between populations and demographics. And they all have cultural considerations for engaging the demographic and providing service. We're currently under the funding allocation from the Department of Mental Health and with an intern from the New England Public Health Training Center doing some research, which will be the focus of a future webinar and technical assistance on recommended practices for several of these populations at higher risk. The organizational self-assessment does not make any connections between suicide services and cultural considerations per se of special populations, risk factors, and substance misuse. But since the OSA aims for universal screening and appropriate treatment for everyone when risk is identified, we want it to take into account the high-risk groups and diverse groups, cultural considerations for service that we have to consider. So these topics may come up in an agency's process of completing the OSA. Again, we hope to learn from one another, from what the research in the national field is telling us, and also about what we're learning about working with these populations in Vermont. The OSA does have a focus on use of evidence-based practices such as CAMS, we've mentioned earlier, the Collaborative Assessment for the Management of Suicide, and dialectical behavior therapy. These approaches might have some consideration of cultural issues. Michael, I want to ask, are you working or have you worked? We have just a couple minutes left if you wanted to comment for just 30 seconds or so as an agency if you're working on any of this.
Yes, I think that we really, all of our messaging is constantly looking at almost every one of these populations that you're talking about, especially in terms of the LGBTQ population. We're starting a survivor of suicide group, and in part we're been invited to use the space of a new center opening up in Morrisville for supporting that population, so that we can try to create an atmosphere that folks who may be reluctant to talk about suicide or having some of those feelings feel like it's part of the structure that they're joining in that case. We also are always emphasizing substance use as a risk factor, not only because of some of the physiological things that happen when people use, but also because very often people who are using are increasing their risk because of the kind of atmosphere that they find themselves in as they're using. The depression can increase, hopelessness can increase, etc. So we're pretty constant on those two areas, as well as I think every one of the other areas you talk about.
Thank you. Okay, moving ahead and just winding up in the next couple minutes, thinking ahead about your next steps, securing organizational leadership support and approval, identifying who you would engage in a zero suicide core team, and considering a timeline for conducting your organizational self-assessment. Please remember that next week, webinar number 4 will focus on using the Zero Suicide Workforce Development Survey. Also, please remember the help resources in Vermont, natural peer networks, as well as calling your local mental health agency or independent providers, texting the Vermont Crisis Text Line, or calling the National Suicide Prevention Lifeline. The National Suicide Prevention Resource Center is our source of technical support for much of the work we do here in Vermont, and also has a great website on which you can access resources. Many of those resources are found at the Vermont Suicide Prevention Center resource website, www.vtspc.org. You would go under the resources menu to Zero Suicide. And under the Zero Suicide menu, you'll go down to Tools and Resources to support Zero Suicide, which includes the OSA and the Workforce Development Survey, which will be the focus of next week's webinar. And then this spring, in April, we will announce the dates shortly. The Zero Suicide Practice Skills Institute will be held to bring together teams of clinicians to learn more about the evidence-based practices for screening, assessment, suicide-focused care, and care coordination. The Skills Institutes have been launched in Vermont twice before, and they really were the initiation of our first round of pilots, so we're looking forward to bringing new teams together to work, learn, and share. As always, we would like to summarize and say that the Vermont Suicide Prevention Center stands by to provide support to state initiatives, to regional initiatives across sectors. We're very committed to the issue of suicide, but also to comprehensive health promotion and moving this issue upstream. We're looking for partners to work together collaboratively, either as a backbone organization or in providing technical assistance to bring together the many partners that we work with to move forward in the field. In summary, leadership, commitment, and support are critical. The Zero Suicide OSA is designed as an assessment and planning tool to establish priorities. And we're learning from early adopters. So we thank you all for the work you're doing. There are resources available to assist you, and we look forward to moving forward. Finally, we always emphasize self-care in this field. Taking care of yourselves and ourselves is really a critical part of the work. So we hope that you will take that into account as you move through your day today. Thank you for joining us. And in just a moment, an evaluation will pop up. We ask you to please complete it, as we need to know the feedback on how we can improve these webinars and or bring new services to the field, and also for reporting to our funders. Thank you. Oh, the websites. Yeah. I think that we'll leave that for next week.